at George Washington University and the Director of Medical Education for the Metabolic Medical Institute. These two organizations are working together to promote integrative medicine education. We have a very exciting upcoming weekend at the very end of October, beginning of November in Miami, where we'll be presenting a number of different topics related to wellness, vitality, and human health. Today, we have a wonderful and exciting colleague, Dr. Burdette, who has done some very innovative work in the field of integrative medicine. We are excited to have her present at the end of this month, and today we'll be speaking to her about her background in training, as well as the work that she's been doing both in the fields of medical toxicology as well as gastroenterology and digestive health. So thank you, Dr. Burdette, for joining us today.
Absolutely, my pleasure.
Dr. Burdette, tell me a little bit about your background in education. How did you get into this field in the first place?
Yeah, so way back in undergraduate, I was dual majoring in pre-med and psychology, and I got near the end of that and thought, surely these two must intersect in some way. Surely the mind and body are not two distinct studies. And so from there, I started looking for programs that gave integrative medicine training. And there weren't that many to choose from at that time, but I did find schools that taught naturopathic medicine. And I didn't even know what a naturopath was, but the training that looked at a Western-style diagnosis, doing histories and physicals, but then using things that were less invasive and up the ladder of invasiveness until we find efficacy, really appealed to me. And there was, of course, in that field also a recognition of a mind-body connection. And so that's where I found myself in school. I went to Bastyr University, one of the few naturopathic medical schools at the time, and I thought that I was going to dual major again. I thought I was going to get a PhD MD. That program didn't really exist at the time, but I've always had a love for research, a love for study design, and so from there, went into private practice, really enjoyed working with patients, but really felt that we needed to validate the things that we're doing. And what you said in the intro is you said as something about being innovative, and I really feel like our community at large have been great innovators, but one area that's lagged behind is the validation of what we do. And so moving into laboratory sciences was a natural evolution for me because it really allows to collect data, to see trends, and to do exactly that, validate these innovative therapies that we've been doing that we know are successful, and when we do this, we can reach more people.
Well, I agree, and I think that especially from a clinician perspective, there seems to be, especially within conventional training, a lack of exposure to markers and a way of assessing patients that can be very insightful and helpful with regard to what might be going on with their metabolism. And with that being said, tell me a little bit about the work that you'll be presenting on detoxification pathways and how important you feel that is in the context of helping your patients, because we know that chronic low-grade exposures impact human health, and yet we still have a challenge, especially within academic circles, to expose that idea and to bring credibility to it. In my medical training as an MD, I was taught that it was really only acute exposures that we would worry about, as opposed to the chronic low-grade exposures that we all experience now, and sort of those gene-host interactions and sort of how healthy the detox pathways are that really matter for individual patient health. So tell me a little bit about your perspective on that.
Yeah, so I think that as the paradigm begins to shift, we begin to realize that we can use biomarkers for more than just a strict diagnosis of pathology. And the story of detoxification probably really exemplifies that quite well. So in terms of laboratory tests and liver function and detoxification, what we're usually looking at, what we're taught to think about, is often things like an AST or an ALT, a liver enzyme. And when you see that elevated, you know that you're in liver failure, that there's some type of destruction going on, and then that gives you your diagnosis. Well, unfortunately, long before, or maybe fortunately, because we can pick it up and we can do something about it before you get to that pathology, but long before a destruction of the liver occurs, dysfunction is going on. And so while that dysfunction, while having to process things from the environment or or having to process inflammatory mediators from our own body, which can get in the way of how we regulate other hormones or things that we call our medications or even botanicals or nutrients that we come into contact with. So why that dysfunction can be really important to a process. And so that process can be the underlying process of inflammation, or can affect even nutritional deficiencies, or could affect our burden of toxicants in the body. And that's not a strict diagnosis, but it's a process that can make many pathologies worse. And so some of our limitation comes from exactly that, lab sciences and how we were taught to look at things, which is biomarker equals diagnosis. But the exciting thing about the paradigm that we're moving into means that now we're looking for this process even before a diagnosis occurs, or if after the fact, to recognize why it occurred so that we can do something about that. So, for example, if we can look at genetic polymorphisms in somebody's liver, then we can start to say, even before they get a medication, that medication is not going to work as well for them. They won't activate it, or they might process it so quickly they won't get a level to achieve therapy, yet can still be at risk from addiction. Let's say if it's a pain medication, something of that nature. And so if we can start to look at the process, and we can start to look at the individual, then we can start to unravel why a pathology might occur, and we can use that to direct treatment, what's going to be most specific for that individual. And so now, even though a lot of medicine comes down to an N of 1, that person in front of you, we're able to have an evidence-based approach around that by looking at their specific polymorphisms, by looking at their ability to do phase 1 and phase 2 liver detoxifications, and now make an educated choice without as much trial and error process.
And what are some of the key areas within the domain of detoxification pathways and intoxicants that you typically consider when you're listening to a patient and you're beginning to wonder whether or not impaired detoxification or the role of toxins might be participating in the illness context for that patient?
So some of these things might be obvious. So when I'm taking a history and I start to recognize that maybe somebody is very sensitive in different environments, that they react strongly to chemicals, or that they need less of a medication than is typically prescribed, or if they have what are called pathologic reactions to things, something that should make them drowsy wires them, or vice versa. These are signs to me that metabolism in the liver is not working as it should. But there can also be things that we might not have thought of as clearly that might not jump off the page to us. So for example, in a patient who has more gas, bloating, irritable bowel syndrome, Crohn's or colitis, we're really starting to build that link between the microbiome and what's happening with the liver, that enterohepatic circulation, that communication between the two, not just circulation, but also the influence of the microbiome on our own genetics and how that helps protect us and also helps us to detoxify.
And what are some of the markers that you typically draw when looking at a patient's ability to detoxify?
So if we can back it up and we really start with what's going on in an individual, then we can begin to think about polymorphisms or specific genetic SNPs. We can see if they're going to have difficulty with methylation or glucuronidation or certain pathways that majority of medications are processed through. And then from there, once we know that there's a predisposition in a certain direction, we can use that to now choose what markers we want to look at to see functionally if this causing impact in their system. Even though there might be a genetic polymorphism or a SNP, there can often be other genes that will compensate or things that can be upregulated. And so it doesn't necessarily need a one-to-one correlation with functional output. So now, based on where we see the problem, we can be, maybe if we see more of a methylation problem, we can know that we need to look at things like homocysteine more frequently. Or if we see problems with glucuronidation, we can look to organic acid testing to see how these things are being eliminated. Or if we think that there might be some type of microbiome interaction with the liver affecting detoxification, we can look to markers like piperate or benzoate that are also found on an organic acid that often come from dysbiotic bacteria and would tell us how certain pathways like phase 2 glycination are also doing in the liver. So we can start with somebody's genetic background, but we can use that to now tailor based on exposures, what we learned from the history, and also fold in their genetics, what functional markers we should look at to really see what pathway they're on.
And tell me a little bit about some of the typical treatments that you might use to help detoxify a patient.
Yeah, so this too will vary based on severity of exposure, what they're exposed to, and where there are different polymorphisms. But in general, it really opens us up to be able to use a wide range of very wholesome therapies that are quite effective. So I think back to when I joined the practice that I've been at for over a decade now. And when I came to that practice, a real tenet of that practice was to start people on some type of detoxification protocol. And I remember thinking, well, you know, I've been taught to individualize everything, and not everybody's going to need to detox, and we need to not have these kind of blanket approaches to things. But I have to say that I think that there was a bit of being naive with that approach, and maybe not everyone needs to detox unless they live on this planet, but if you live on this planet and you breathe this air and you eat this food, the chances are likely that you could derive benefit from this. The therapies then that we get to use, actually we can start with things like water, and we can move up the ladder to different foods, looking at things like cruciferous vegetables or looking at garlic and onions for their sulfur properties to drive phase 2 sulfation, and then keep moving from there to things like glucosinolates and sulforaphane that come from broccoli, more concentrated, and will work on specific pathways of the liver. Different milk thistles, certain nutrients, alpha-lipoic acid, and N-acetylcysteine, amino acids such as glycine. So there's a wide array of therapy, but one of the things that we're going to talk through is based on exposure and based on genetics as well as clinical presentation, when do you choose what therapy?
Well, to me it sounds like it's really important for what you'll be presenting in Miami for all of us as practitioners. And I think it's an area that we need to return to often and challenge what we already know and continually improve in terms of dealing with handling patients who clearly need support with detoxification. It will segue well with Dr. Cavalieri, who I just spoke with. He's from the University of Nebraska, and his research team has demonstrated some incredibly important work on the role of estrogen adducts and how they bind DNA, and that in fact over the last 19 years or so, his work is beginning to reveal that the cause of a number of different cancers is alterations in particular in estrogen metabolism. And
I think that,
go ahead.
Yeah, I think that's an excellent point, and you can't help but to think about the intersection of the environment with that. So, for example, when you start thinking about the #1 pesticide used out there, glyphosate, trademark name Roundup, well, it turns out that it actually inhibits one of the enzymes, CY1A1, that has to deal with how we metabolize estrogen. So, absolutely, these estrogen adducts, when estrogen moves into these semiquinones and can interact with your DNA more, that can set us up for breast cancer. And it turns out that there's a logical intersection with the environment that we're in and that occurring.
Yes. And his perspective is that while we can certainly talk about the environment and its role in altering estrogen structure and inducing the 3,4 quinones, his focus is really on the damaged estrogen itself. That's the final common pathway. And not just for breast cancer, but they've shown links to prostate cancer, lymphoma, and a variety of other cancers that often aren't talked about in the context of abnormal estrogen metabolism. So I think the work that you're doing, paired with the work that Dr. Cavalieri is doing, begins to build a very important story along these lines. But I want to shift gear now because you're also going to be giving a lecture on advanced digestive markers and the role of digestion in the process of human health. I think this is one of the most important contributions that integrative practitioners such as yourself have made to the field of medicine broadly, especially from a functional and dynamic perspective, because again, as a conventionally trained physician, we really get very little training in looking at the functionality of the gut and how important it is. We also had Dr. Fasano coming in from Harvard to talk about the role of gluten with regard to chronic inflammation and even autoimmunity. We have Dr. Linda Lee from Johns Hopkins, who will also be talking about functional gastroenterology and integrative gastroenterology. And you'll be a part of that discussion as well. And I want you to speak a little bit about these markers that you'll be discussing.
Well, and I have to say that I'm a huge fan of Fasano. He's an excellent speaker, and he's made a lot of contribution. And one of the areas that he has made such a deep contribution to is exactly that area that I spoke to earlier, which is validation of what we're doing. I can remember, again, sitting back in naturopathic medical school and somebody introducing the idea of leaky gut. And I remember when I heard that term, I remember thinking, what is that? It sounds made up. I'm going to do what I always do now, which is go to the research and see if I can validate this in any way. And when I went to PubMed and typed in leaky gut, nothing came up. But fast forward to today, and because of Fasano's work, now when you go to PubMed and you type in leaky gut, you see a large body of research. And again, we knew years ago that changing the diet and working with the gut was having profound effects, not just in colitis and Crohn's, but in depression and joint pain and these systemic areas that one would argue, or might have argued, were not directly gut related. So we knew what we were doing was working, but the mechanism of how and why was still left out there. And when we can't answer those questions, we can't communicate with the larger communities, and it limits our ability to help more people. So having some markers that evaluate what's happening in the gut and help us trace through that story of how something that starts in the gut can affect us systemically becomes hugely important. And just a simple analogy that I use to explain to patients about this is I talk to them about how their gut is the size of the tennis court. And if something the size of the tennis court inside your body is either inflamed or tolerant, immune tolerant, that is a huge difference. And so these biomarkers like sonulin and LPS and diamine oxidase give us direct markers that show the integrity of the gut, but then what they also allow us to do is to see when these markers are out of range, either elevated or suppressed, what pathology correlates with that? What pathology correlates that when these markers are off even before the pathology shows up? And so Fasano's work specifically around zonulin in this area, he was able to show zonulin, a marker of leaky gut, when that was high, predisposed people to autoimmune conditions, different neurologic conditions, even certain cancers, really validating that connection between inflammation in the gut and that inflammatory process moving systemically, washing over our genetics until eventually a pathology is expressed. So he's taken our anecdotal experience and really tied it together with the science so that we're able to communicate this idea more effectively, so we can track it more effectively, and we can treat it more effectively.
Tell me a little bit about the role of histamine in leaky gut.
Yeah, absolutely. So that's another good example of something that we tend to put in a box, and we say, yeah, histamine, that's allergies, that's its place, and that's how I'll think about it. However, when you start to dig a little deeper, you quickly realize, well, there are histamine receptors in the brain. There are histamine receptors in my heart. And so if that's the case, what's going on with that? So literature around levels of histamine either being neuroexcitatory or contributing to depression or mania, or even schizophrenia, depending where your level is at. But the place that we start to generate most of this histamine, again, tracing it back to the gut, and again, there's an individualized story. And so alongside histamine, how do we shut those reactions off? How does the body deal with that? And so there's a complicated story to that, and different compounds in our bodies like lactoxins and resolvins that will turn off inflammatory reactions. But in this case, also a marker called diamine oxidase, the enzyme that degrades histamine, which is produced in our gut. And so the healthier the gut, the more plumped up your microvilli are, the more diamine oxidase you make, which means you have a better ability to degrade histamine. So of course this is important for allergies or asthma or something atopic, but it's also important for MS, where MS patients have more mast cells, the ones that release histamine, in their brain than controlled. Also important for arrhythmia, where a subset of people with arrhythmia have more mast cells in their heart than controlled. And so the more we're able to control and degrade histamine appropriately, the more we can control triggers for, yes, allergies, but also things like arrhythmia or mania or depression, or even MS and schizophrenia. So again, that connection between the gut and these things happening systemically.
And that's a really important point to make, because if you look at how that weekend is organized, we spend time evaluating and discussing sort of functional aspects of digestion, looking at new markers that help us to better understand what's going on with our patients. But then we move into a broader immunologic discussion and the role of both innate and acquired immunity in the context of gut-immune interactions, as well as biological exposures and toxins. And then the final day, we make our way into the nervous system and the brain in particular, and how shifts in digestion and shifts in the immune system begin to change and alter how our brain in particular functions, and the ways in which that's expressed through mood, as well as cognition and even neurodegenerative diseases. So what you're talking about is the gut immune shifts and the gut-brain interactions that I think are central to a lot of disease processes that are often not well understood. And yet we always see overlap between mood disorders and irritable bowel, or cognitive disorders and inflammatory processes. And I think you've been very eloquent in sort of discussing some of those links that we'll cover during that weekend in depth.
Well, it's a very exciting area to look at when we get the opportunity to be less reductionist and start think about these interconnections. Of course, it adds a level of complexity and can sometimes seem really overwhelming, but at the same time, it gives us more opportunities and more treatment directions, which ultimately means more tools in our bag and more people that we're able to help.
Well, I couldn't agree with you more, and we are delighted that you'll be participating at this upcoming Metabolic Medical Institute weekend in partnership with George Washington University from October 31st to November 2nd in Miami. People can sign up at mmimedicine.com. And Dr. Burdette, thank you for your time. This has been a wonderful discussion, and I think very enlightening. I hope people are excited about coming and listening to you, as well as all of the other experts that we've collected from around the country to discuss these topics.
I'm really excited. I think you've done a lot of work to make this unique from other seminars, more collaborative and more interwoven so that we can really move from that bench to bedside and really put these things into practice.
Thanks, Dr. Burdette, and I'll see you in a couple weeks.
All right. Take care.
You too. Bye-bye.
Bye-bye.